In this video, we'll be talking about trauma. So what and all orchestrations can come, what are the different scenarios can come. So in a tabular form, we'll go ahead and we'll discuss. So usually when the OSCE of trauma comes up, it will be an pre-alert. So you'll be having pre-hospital information given by paramedics. They will be giving you the information usually in the form of MIST, which M stands for mechanism. What was the mechanism of injury? What were the injuries sustained? What were the signs and symptoms which are present in the patient? And what were the treatment given? And after that, you might have to activate the trauma team. Most of the time, if the mechanism of injury is dangerous, or the patient is hemodynamically stable, or it is a penetrating injury, you end up calling an trauma team. The different things which you can come across, for example, there is a dangerous mechanism of injury, or if the age is more than 70 years, or there is another death. So there were co-passengers' death in the same accident. For all these mechanical reasons, you will you will activate the trauma team. Injuries, there might be an upper airway obstruction, or there might be two body regions involvement. For example, an upper limb and an abdominal injury, or a chest and abdominal injury, or an upper back and lower limb injury. Then you need to involve two long bones injury. For example, humerus and femur is involved. Any suspected spinal cord injury, any amputated limb proximal to the wrist or proximal to the ankle needs to be activated. Any penetrating injury over any part of your body, or if the burns are more than 15% of your body surface area, or if the patient is hemodynamically unstable, activate trauma team. So once you have activated trauma team, you collected enough information, you will be having your team available. Most of the time in the OSCE station, the entire trauma team will not be available. They'll give some other reason that this person is not available, that person is not available. Usually in any scenario, you will be having one nurse and you'll be having one doctor. So usually it will be a middle grade doctor who will be available, who can do a little bit of that and little bit of this. So basically you need to know the level of competencies and assign the roles accordingly. Once the paramedics comes in, you take brief amount of time to listen to what paramedics is telling. Don't directly jump on the patient. Before entering the room, the pie chart what is given, have a closer look at the pie chart. If the marks maximum carries for the resuscitation skills, then they are expecting you to assess the patient and perform the interventions. If that pie chart says maximum, in that pie chart, it mentions that maximum marks are allocated for team leadership, then adopt an hand-free approach. That means you'll be standing at the foot end and just giving the commands. So your team leadership is, or the leadership quality, what they are assessing here. So they're expecting you to lead the team, not involved in the intervention or assessment of the patient. You're just telling them to assess, they'll be giving you the feedback and you're taking the decisions and you're leading the team. Primary survey. Primary survey here, along with airway, the difference is C-spine protection comes in. Breathing is similar. Circulation, hemorrhage control is the additional thing. Disability is similar to that of the medical cases, and exposure is kind of similar to that of the medical cases. Here, mainly we are seeing for any deformities if present, especially of femur or the thigh deformity, which can cause significant amount of blood loss. If it is a burn case, here we can see the percentage of body surface area which is burn, which is more than superficial burns. So let's see briefly in each one of this what we supposed to do. So in airway and C-spine, you need to do 3-point neck immobilization if it is not already been done by the paramedics. So in some scenarios, they might already have an C-spine and 3-point immobilization, so nothing much to be done. In some scenarios, they might have not done anything at all. That's when you need to do 3-point immobilization. Then assess for the airway patency. If the patient is able to talk to you, then you can assume that patient is having a patent airway. Just start them on high flow oxygen. Or if there is any gurgling, added sounds like gurgling, striders, snoring, that might be suggestive of a foreign object, or tongue fall, or low GCS causing a tongue fall. So you might require some airway maneuvers followed by airway adjuncts. Suctioning in on and off suctioning might be required, followed by definitive airway. We'll discuss about this in coming up slides. In breathing, You need to check respiratory rate, saturation, tracheal position. Tracheal position becomes important. If it is deviated opposite to the site of lesion, suspect a pneumothorax. Check for the chest expansion. Chest expansion will be reduced on the lesion sites, usually in hemothorax or pneumothorax. While inspection, you need to look out for any open wounds are there and there is a bubbling sound. If open wound with the bubbling sound is there, suspect an open pneumothorax. Also look at the neck, which might there might be few dilated neck vessels. Dilated neck vessels are suggestive of two things. It might be a pneumothorax or it might be a cardiac tamponade. Then palpate the chest. Mainly, we are palpating the chest to look for any subcutaneous emphysema, that is crepitus, if you're feeling at all or not. After we have finished inspection, we have finished palpation, then comes percussion. So in percussion, if there is a tympanic node, it is normal. If it is hyperresonant, it is pneumothorax. If it is dull, then it is a hemothorax. Auscultate always one thing for the air entry. Main thing, if the air entry is reduced at one side, it might be pneumothorax or hemothorax or hemopneumothorax. You can auscultate for the chest also here, but most of the time the heart sounds are done in circulation. So S1, S2 comes in circulation, though I have mentioned here. It depends on you, but for the exam purpose, auscultate for the heart sounds in circulation. Coming to circulation, check for heart rate, blood pressure, capillary refilling time, especially the central one. So on the sternum, you'll be pressing for 5 seconds, counting 1, 2, 3, 4, 5 over the sternum, then relieve it and see whether the capillary refilling time is normal or not. Normal is less than 2 seconds. Correct on cardiac monitor. If there is any obvious source of bleeding, stop it. For example, there is spurting of the blood, apply the pressure there. If pressure is not applying, dress it up, then apply the pressure. That is not working, use a tourniquet. Involve the surgeon as soon as possible so that they can stop the bleeding. At the same time, you might see a deformity of the lower limb. If there is a deformity, especially of the thigh, where enough fluid or enough blood can be lost to cause hemodynamic compromise, then you need to splint it. So Thomas splint needs to be applied. That takes over the resuscitation part. So get into a large AV ball cannula, examine abdomen, pelvis, then look for long bone injuries and apply the pelvic blinder. Never forget to get an fast scan done. If the patient is in shock and you have controlled the source of bleeding, then you activate major hemorrhage protocol, start with fluid resuscitation. Once blood products are available, start with O negative, and once cross match is available, start with cross match blood. Always assess for GCS in adults and AVPU way of assessing GCS in pediatric age group. Check for the pupillary size, that's important. Check for the glucose size. Lateralizing signs is only important. Lateralizing signs might be important if you're thinking of a spinal cord injury, especially in Brown-Sequard syndrome. Okay, this one you have all come across in the SBA exam. Typical question in an exam, SBA exam. In exposure, check for the deformity if you're missed in circulation, especially for the thigh. If it is a burn case, calculate the percentage of burn here and check the temperature. So it kind of remains same. There are few changes which happens with each scenario, which I'll be discussing as and when the scenario comes up. So first we'll be discussing about C-spine immobilization followed by airway management. C-spine immobilization always is a 3-point immobilization. Okay, so you need to, once you receive the patient, you need to do a manual immobilization, call for some help. With that help, usually most of the time, if it's not a single station where you're just doing a C-spine immobilization, because it takes a little bit of time. If it's not a single station, if it's a proper station trauma case, there will be some assistant for you who can immobilize. Just tell them to do it and 3-point immobilization. What does this 3-point immobilization means? So 1 point is applying a C-collar. Another point is using head block. The another point is using tapes. One tape is over the forehead, another tape is over the chin. So you are immobilizing the neck movement in all possible directions. So you shouldn't be able to move the neck at all in any direction. That is the aim of getting the C-spine immobilization. If the patient is quite agitated, if the patient is not cooperative, then you can avoid C-spine immobilization, because an agitated patient or uncooperative patient, it can cause more harm than preventing the worsening of the C-spine injuries. Coming to the airway management. So first thing you need to do is inspect what you're looking for here. Any obvious facial deformities are there because of the trauma. There might be one side flattened or one side shattered completely. There might be few teeth lost, or there might be complete facial burns. There might be circumferential neck burns. So closer, have a look. After having a look, listen. What are you listening for here? We are basically listening for any added sounds are there. Is the patient gurgling? Is the patient snoring? Is the patient is having stridor? Is the patient having hoarseness of voice? Or in a burn case, are you seeing any facial burns, neck burns? Is there any nasal hair burns? Or is there any eyebrow burns are there? Or is there any, he's producing carbonaceous black colors, sputum or secretions are coming out of his mouth? So look and listen first. If you look and listen, you will suspect there might be an airway obstruction with the signs and symptoms what I told you here. Once you have done that, you want to see inside the oropharyngeal airway. So inside the mouth, you want to see what is happening. So how to open? Always maintain, so always have an manual. So to assess it, you can't have head blocks, everything to assess it. So you can just open it, ask the person who is along with you, ask the nurse to do a manual inline stabilization. Once manual inline stabilization is done, then use this technique. This technique is known as jaw thrust technique. So basically, at the angle of the mandible, you're placing your fingers and you're placing your palm over the zygomatic arch, and you're pressing over the zygomatic arch and lifting the jaw up. Once you lift the jaw up, the oral cavity is opened up. In the children, the aim is to have the face parallel to that of the roof. You can achieve it by placing a thin cloth of sheet just below the shoulder blades. That will cause slight extension or the C1 level, C1, C2 level, and slight flexion at the cervicothoracic vertebrae level, which will cause the head to be parallel to that of the roof. So now we have opened the airway. Once we have opened the airway, look for any secretions. So it might be a foreign body, it might be some blood, or it might be some food particles, or it might be a broken tooth, or it might be just a fallen tongue. So if you see any foreign body or secretion, just suction it out, remove the foreign body using a McGill's forceps, remove it. Okay, in children's, usually the larynx is funnel shaped, allowing the circulation to get accumulated retropharyngeal area. So it might, due to the funnel shape, it might get accumulated really back of the throat. So suctioning might be slightly difficult. But what you're seeing, you're suctioning, don't blindly go ahead into the oropharyngeal airway without visualizing. So you need to visualize. If you see something, you suction it out. If you see some foreign particles, you remove it out. Next, what is the step? Still, the patient is not improving after doing all this suctioning, then you're suspecting there might be a low level of consciousness. That's why the airway is not patent. So if the patient is not responding at all, then you use it an oropharyngeal airway. So unresponsive patient, oropharyngeal airway. Responsive patient, there is some response with the patient, then use an nasopharyngeal airway. If the patient is unresponsive, then you are using oropharyngeal airway. You need to size it to the patient. So from the angle of the mouth till the angle of the mandible, you size it. If it's from the angle of the mouth to the, if it's in the same size as I drawn here, then you place it back as shown in this image. So first you go inverted, then after the halfway, you again rotate it by 180 degrees and place it inside. So if you are able to place an oropharyngeal airway, that means the GCS is less than 8. If the patient is tolerating oropharyngeal airway, that means there is loss of gag reflex. If loss of gag reflex is there, that indirectly indicates that GCS is less than 8. You need to intubate these patients. If they're not tolerating OPA or the patient is responsive, then you put a nasopharyngeal airway. Nasopharyngeal airway, usually the diameter, you take it off a little finger and you gonna go ahead and place it. So we'll be having an tutorial on this procedures, how to do it. So don't worry, it's just In proper trauma resuscitation case, you need to just verbalize what I'm telling now here. So he's tolerating OPA, so you want to go ahead with an advanced airway, that is endotracheal intubation. So what are the steps for endotracheal intubation? You need to open the airway, jaw thrust only. You can't do head tilt, chin left, or you can't do a snipping position, which is very important, or which makes intubation easier. Pre-oxygenate. You do it for 3 minutes with a high flow oxygen using bag valve mask. You just gonna oxygenate, or if it's breathing on itself, you're gonna put the patient on high flow oxygen for 3 minutes so that there is washout of nitrogen and it is replaced by oxygen. Maximum amount of normal atmospheric air contains nitrogen. So you want to replace all this nitrogen by oxygen only, because when you're intubating, you get that additional few seconds where the patient doesn't go hypoxic and you can go ahead and intubate. Make sure you have the intubation drugs available. Just say, I need all the intubation drugs available according to the hospital protocol. That should be sufficient. Unlikely they will be testing you which drugs needs to be used. Okay, but just remember there are 3 kinds of drugs you needed. One is for induction. One is for induction, as I told you. Another one is for muscle relaxants. Another one is analgesia. So 3 classes of drugs are required and 3 drugs are required. Then you're going to apply the required pressure, just applying going backwards. Do an laryngoscope, go ahead and intubate. Once it is intubate, confirm the tube placement. So how do you confirm? The best way to confirm is visualization of passing the tube through the vocal cord. Second best way is using an waveform capnography. Then you can use other methods like calorimetry, as mentioned here. Then you can auscultate the chest to looking for air entry, bilaterally equal or not. So those things you can do it later, but direct visualization and waveform capnography are the 2 preferred way to confirm the endotracheal intubation. Sometimes it might be a difficult intubation. Then you need to follow this algorithm. So yes, you have failed first time, what to do next? So try to optimize the head neck position. See whether neuromuscular agents what you're given are adequate or not. You can try and use, if available, use an video laryngoscope here, as mentioned here. Do an external laryngeal manipulation. If required, use bougie. Remove the cricoid pressure and see if it's required. Okay, you can do a maximum of 3 attempts. 1 additional attempt is given for the experts. For example, a senior anesthetic consultant is available, then you can give 1 more extra attempt, or else who are not very well versed with intubation, 3 attempts are given. Okay, let's see what does they mean by sorry, let's let us have a look here how to manipulate so that you have a better visualization of the vocal cords. So you can hold the cricoid cartilage using your thumb and index finger, as shown here, index and thumb finger. Then you need to apply backwards pressure, then push it upwards, followed by going on the right side. This will help you to better visualization of the vocal cords and will help you with the intubation. Again, this is a plan A. If this plan A fails, then what you do is you try to use 2nd generation supraglottic airway devices. The preferred 2nd generation supraglottic airway device is iGel, which is most commonly used in the UK. Again, you try different sizes. If it is not possible, if you're failing, then you go for bath mask ventilation. If you're able to succeed with bath mask ventilation, wake the patient. If the plan B is succeeded, is the intubation absolutely necessary or not? If not necessary, wake the patient up. If it is absolutely necessary, then go ahead with tracheostomy or cricothoracotomy. You can get the extra support. You can buy the time to get the extra support. If bag mask ventilation fails, then you need to do emergency front of neck access. So sometimes they might ask you a station itself to manage and difficult airway, basically how to intubate and difficult airway. So to summarize, maximum 3 attempts are given along with doing an external laryngeal manipulation as shown in this pics. along with using bougie and along with using video laryngoscopy, maximum of 3 attempts. One additional attempt is for the expert. If you fail, then we use second generation devices. Again, maximum 3 attempts. Second generation devices, if they ask, name it as iGel, which is most commonly used in UK. If this one fails, then you do an bag mask ventilation here. If you succeed, you wake the patient. If you fail, then you get in front of neck access. How to get in front of neck access? In pediatric age group, the anatomy is not that well versed. That's the reason they prefer doing a needle cricothyroidectomy. This is a temporary measure till you get enough help to do an proper tracheostomy by involving an ENT surgeon or by involving a qualified person to do an tracheostomy. So what we do here, so we pass a needle in 45 degrees, okay, with a continuous negative suction as shown in this picture. Once air bubbles are there, you stop it and keep this needle in and connect to an oxygen. So you keep this oxygen on for 1 second and off for 4 seconds. 1 second on for inspiration, 4 seconds off for expiration. What's the oxygen flow liter you need to keep? It should be 15 liters per minute for adults and for children according to the age. For example, if the kid is 4 years old, it's 4 liters per minute what you're connecting at oxygen flow. If it is 10 years old, then it is 10 liters per minute what you're connecting for. Surgical cricothyroidectomy is a preferred one, and it is and kind of buys you more time, and you can keep it as a permanent, and you can ventilate this patient. Here you cannot ventilate this patient. You can just give the oxygen. The ventilation has to be done by the patient itself. So this is a more likely method in the adults, more preferred method in the adults. First, palpate thyroid gland and the cricoid cartilage. Right between that is a cricothyroid membrane. Once you palpate the cricothyroid membrane, do an horizontal incision as shown here. Okay, once the horizontal incision is done, you keep doing blunt dissections. Okay, once blunt dissection is done and you are in the trachea, then you pass 6-size ET tube, 6-size curved ET tube usually. Use the dilator to get the enough space to pass and 6-size ET tube. Unlikely they go to this extent because these are all more consultant level what they are asking. But have a look. If at all, if it comes up, you can at least pass the station by just verbalizing if you're not able to do it practically. So just to summarize, first look and listen. You're looking for any deformities, any obvious fractures. You're listening for any added sounds like gurgling and like gurgling, snoring. Then open the airway. When you have this added sounds in the airway, if you see a foreign body or secretions, you remove it, do a suction. If still the patient is not maintaining airway, still the patient is having sounds, most likely because of the low GCS. So because of the low GCS, if the patient is unresponsive at all, then you use an oropharyngeal airway. If the patient is responsive, then you can use nasopharyngeal airway. If the patient is tolerating oropharyngeal airway, that means there is loss of gag reflex. Loss of gag reflex suggestive of low GCS, then it needs an intubation. Go ahead with endotracheal intubation. So the step of endotracheal intubation or first position the patient, pre-oxygenate, then give the necessary drugs. Those are 3 drugs are available, needs to be given. Those are skeletal muscle relaxants, analgesia, induction drug, then go ahead and intubate. Once intubation is done, confirm the intubation. Confirm the intubation by waveform capnography ideally, but the best method is visualizing the tube passing through the vocal cords. So sometimes they might give a trauma case and make you stuck here in the airway itself. So you're just doing an airway management. Once you have finished the airway management in breathing, circulation, and deformity, it will nothing be there. It will be everything normal, 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 normal. If you don't do an airway management, if you get into a breathing circulation, the patient will deteriorate. They might say he's gasping now, or it might go into a cardiac arrest. So they are basically indicating go back to the airway and manage the airway first. So once you are in the airway, you need to stabilize the airway before you go to breathing. Once you are breathing, you need to stabilize the breathing before you go into the circulation. Coming to breathing now. Airway obstruction, we have dealt with it. What are the other life-threatening? It might be tension pneumothorax, open pneumothorax, massive pneumothorax, phlegm, chest, and pulmonary contusions are kind of replaced by tracheobronchial injuries and cardiac tamponade. So any one of this can appear in the exam. So we'll be dealing one after the other, this one. Coming to tension pneumothorax, as the name suggests, there is a lot amount of air which is accumulated are surrounding the lung parenchyma, accumulated between the visceral and parietal pleura basically in the pleural space. As you can see from here to here, there is all air, and this will compress the lung parenchyma. So what are the typical features we will be seeing? There might be chest pain, shortness of breath that will cause hypoxia, low SpO2 levels, hypotension because there is increased intrathoracic pressure. So there is venous return from superior vena cava and inferior vena cava is reduced. Because there is no return from superior vena cava, all the neck vessels, if you consider this as neck vessels, the neck vessels will have all distended tortuous neck vessels can be seen. There might be a surgical emphysema because most of the time the air enters to the pleural space when there is a puncture from and fractured rib. On auscultation, there will be reduced air entry. On palpation, there might be some crepitus because of fracture. Along with it, on percussion, it will be an hyporesonance. They might sometimes, they are not yet given this, more often consultant level examination, they end up giving an image of ultrasound. So in the breathing, you'll say, I'll get an EFAST, extended fast, and I'll scan the ultrasound to see it instead of getting a chest X-ray done. As chest X-ray, it will be a simple one. They might just show you this image and ask you, okay, what you'll be doing. So this is a normal image of the lung where you can see here, where you can see there is a transition between this phase and this phase. This is supposed to look like in water. This is supposed to look like in sand. That's why they call it as in seashore sign. When this transition is absent, everything looks like an barcode. So everything looks like an barcode. That's why it is known as barcode sign. This barcode sign is suggestive of a pneumothorax seen when you are placed it in an M mode. Coming to the treatment. So whenever you suspect an tension pneumothorax, clinically, you need not get any investigations done. If at all any investigations you are getting it done, do an EFAST, which might be suggestive of a pneumothorax. But in the examination, on clinical examination itself, if you feel it is a pneumothorax, go ahead with needle decompression. Finger thoracotomy is mainly done in a cardiac arrest scenario where you are suspecting a pneumothorax. Otherwise, it is not required. Okay. After and chest decompression, you need to place an ICD, that is a chest drain insertion needs to be done after that. What is the preferred site for chest drain insertion or preferred site for needle decompression? Both are same according to 10th edition. So follow the 10th edition, that is just anterior to the mid-axillary line in the 5th intercostal space. So how do you assess and go ahead? So patient usually will be able to talk. There will be not any added sound. So you're starting on high flow oxygen. In breathing, what you find is the trachea is divided to the opposite sides. Neck vessels are distended. On percussion, it is hyperresonant. So first thing you do is needle decompression. So you're doing needle decompression before you're getting into the circulation itself. You found something in breathing, so you are treating right away here itself by doing a needle decompression. So after doing a needle decompression, you say that I will be placing an ICD. Please arrange the equipments of the ICD. Till they arrange the equipments of the ICD, go into the circulation, deformity and exposure, that is CDE examination, and finish it off. In C, usually everything will be normal. Everything will be normal. If something abnormal found, we'll be discussing how to manage it in the later slide. So this is algorithm, or this is tabular form for pneumothorax. So pass here, go through with this, how you need to manage this, how you need to tick your boxes when you are in the trauma case, where a pneumothorax is the scenario. Sometimes it might be an open pneumothorax. So in breathing, you are inspecting, there is an open wound, there is open wound with a bubbling sound, you're suspecting, or an sucking sound, then you're suspecting an open pneumothorax. So simple treatment for open pneumothorax is just to do a 3-sided sterile occlusion dressing as shown here. So how to do it? So simple, there shouldn't be any problem here. So in breathing, you're coming across an open wound with bubbling sound or open sucking wound, then you're suspecting it is an open pneumothorax, then you do a 3-sided sterile occlusive dressing. Once 3-side occlusive dressing is there, say I need to place an ICD. Till the equipments are arranged, you will go ahead and assess circulation, breathing, and exposure. So definitive treatment is just tube insertion here also. So you're entering into the circulation and go ahead, disability go ahead, exposure go ahead, no changes as discussed. The general way to examine, you'll go ahead and examine, no changes will be there. Coming to massive hemothorax, it is called as a massive when the fluid accumulated is more than 500 ml in the pleural space. By definition, when we put an chest drain, if there is a drain of more than 1.5 liters, or if there is a continuous blood loss of 200 ml per hour for consecutive 2 to 4 hours, that is suggestive of a massive hemothorax. So massive hemothorax, as shown in this X-ray, here you can see it is all white in color, suggestive of a massive hemothorax. What is the treatment for it? Place an ICD. So what you can do here, start him on high flow oxygen. ICD placement, you can just tell them if the equipments are ready, then you go ahead and place the ICD, then you go into the circulation. If the equipments are not ready, you're going into the circulation, then you are getting back and placing the ICD. Always remember that till A, B, C, D, E are stable, never go into secondary survey. What is flail chest? Flail chest is nothing but paroxysmal movement of the chest wall. It happens when 2 consecutive ribs or fracture are 2 different sides. So there is a segment which is not connected to the ribs at all, and there is no splinting happening at all. So most of this flail chest are associated with hypoxia. This hypoxia is not because of the paroxysmal movement of the chest wall, it's because of the underlying pulmonary contusion. So underlying pulmonary contusion will cause hypoxia. The complication of underlying pulmonary contusion is eventually can develop ARDS. That's the reason all these patients need to be admitted at least in a level 2 care when anesthetics are available around the clock so that they can assess, if required, get an advanced airway or give an support for the ventilation and breathing. So it is a level 2 care where you need to admit these patients. So what's the treatment if you're suspecting an flail chest here? Usually when you suspect an flail chest, it's when you're looking for chest expansion and when you're inspecting. On inspection, there might be an paroxysmal chest wall movements present. If there is an paroxysmal chest wall movements, then think that there will be an underlying pulmonary contusion. Get an pervertebral X-ray done, connect him on high flow oxygen, get good painkillers. Usually the chest expansion will be not that great, that leads to pulmonary contusion worsening, causing infection. So you need to manage the pain so that the chest wall movements are good. So you give good painkillers. Usually they end up giving a block. Interosseous nerve block is given, that is quite helpful. They try to avoid opiates because opiates itself are respiratory depressants. Rest everything remains same. So in breathing, you need to connect on high flow oxygen, give good painkillers like give and paracetamol, give and NSAIDs, give and morphine if required. Go ahead with the circulation, deformity, and exposure. So unlikely because this management is quite simple. Cardiac tamponade, in the history, you need to look for a triad. What this triad is: distended neck vessels, muffled heart sounds, hypotension. So what you're looking for here: distended neck vessels in breathing, muffled heart sounds. You usually auscultate S1, S2 in circulation. There you will come across muffled heart sounds. Once you have hypotension, distended neck vessels, muffled heart sounds, then you involve cardiothoracic surgeon or an ED consultant to an thoracotomy. Thoracotomy is not expected from you to be done, but you should be aware that in an trauma case, when there is a cardiac component, the treatment of choice is thoracotomy, not pericardiocentesis. Pericardiocentesis is contraindicated. It is not recommended to be done in a traumatic cardiac tamponade. So to do an thoracotomy, involve an cardiothoracic surgeon or an ED consultant. That should be sufficient. Rest everything remains same. Here we are using or treating in circulation. You're getting one finding in breathing, that is distended neck vessels. Few more findings, you are getting it in circulation. Then you know it is a cardiac tamponade. Then you're intervening here. How to suspect and tracheobronchial trach? You can only suspect during the examination. To have a definitive diagnosis, you need to do an bronchoscopy. Definitive treatment is operative, so nothing much can be done. Usually what happens, tracheobronchial trach injury. So there is leak of air. So leak of air will cause pneumothorax. So you will pick up the pneumothorax in initial scenario. Then you will end up placing an ICD. After placing an ICD, you notice that air leak is continuous. There is no stopping of air leak. Because in a pneumothorax, there is definitive amount of air. Once that air comes out, there will be no bubbling. There will be no indication of air leak in the ICD, as suggestive of absence of bubbling in the drain, what you are having. If there is a continuous leak of air, suspect there might be an tracheobronchial trach injury. Involve the cardiothoracic surgeon. So to see here, first, everything is similar to that of pneumothorax, but you are noticing that there is continuous leak via ICD. Hence, you are suspecting a tracheobronchial bronchial injury. Refer to cardiothoracic surgeon, because there is only surgical way to fix it. There is no other way you can fix it, and only the definitive diagnosis will get it by bronchoscopy. So you're suspecting here and involving the cardiothoracic surgeons. So it's important to just remember what are the indications or what are the cardiothoracic referral indications. Whenever it is a massive hemothorax, by definition, if it is more than 1.5 liters on initial chest incision itself, or 200 ml per hour over 2 to 4 hours. Any penetrating chest injury, because you're suspecting here there might be a cardiac tamponade or tracheobronchial injury. Any traumatic cardiac tamponates. Any tracheobronchial injury where you're suspecting by continuous air leak in the ICD. Any esophageal injuries, you need to involve cardiothoracic surgeons. Now we are coming to circulation. So in circulation, like any other medical cases, you're checking for heart rate, BP, capillary filling time, peripheral pulses. Next step is stop the source of bleeding. For example, there might be spurting of the blood, so you apply the pressure. Or there might be a deformity of the thigh which is present, so place in Thomas splint, because only the femur long bone injury can cause enough blood to cause hemodynamic compromise. So just look for any femur deformity. After you stop the source, or you're taken a measure to stop the source, then go ahead, get to cannulas in, collect blood samples for blood group cross-matching, blah, 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 as mentioned here, blood group cross-matching, blood gas, renal profile, coagulation profile, get an extended EFAST. EFAST to see basically is there any free fluid. Then do an abdominal and pelvic examination you're doing. Before EFAST, you need to do abdominal and pelvic examination. Then do an EFAST. After pelvic examination, place all the patients who are hemodynamically unstable on an pelvic binder. And you don't remove this pelvic binder till the patient is hemodynamically stable. There is different classification of blood loss. What need to notice here is, if there is only increase in heart rate, there is almost 750 to 1.5 liters blood loss. If there is a low blood pressure, that means more than 1.5, that is 1.5 to 2 liters blood loss is there. Here it will be more than 2 liters blood loss. So more than 1.5 blood loss is already present to have the patient going into hypotension. So don't ignore tachycardia. If the patient is having a heart rate of 110 or 120, don't ignore it. It might be because of the blood loss. The blood loss is already in the range of 750 to 1.5 ml. There will be no hemodynamic compromise. if the blood loss is less than 750. There will be only tachycardia present only and only when blood loss is more than 750 ml. That is more than 50% of the intravascular volume. So you need to give lot of importance to the tachycardia in a patient with trauma. So how to do again management? Stop the bleed. You need to start on IV fluids, blood transfusions, tranexamic acid. Try and please remember the 10th edition of ATLS highly recommends to give tranexamic acid as soon as possible, followed by 1 gram infusion over 8 hours. Okay. Fluid resuscitation, depending on the response, you can take a call. For example, you're given some IV fluids, it has responded very well, all the hemodynamic parameters have come back to the normal, then you might avoid giving blood transfusion. You're given fluid resuscitation, for a few minutes or half an hour, they came back to the normal state, then again they are deteriorating, then you can wait till you have, they will be requiring blood transfusion, but you can wait till you have the cross-matched blood available. There is no response or there is only minimal response with the IV fluids, then what do? You need to start giving uncross-matched blood itself. O negative can be given till the cross-match can be done and you blood available. Till the cross-match is done and the blood is available. So you need to know when to take up for laparotomy. In and penetrating trauma, if the patient is hypotensive, fast scan is not required. Directly involve the surgeons and shift the patient to operation theater. If there is an evisceration like what you see here, or bleeding from the orifices, especially from the PR, if there is a gunshot injury with the trajectory, everyone goes to laparotomy directly. With and blunt injury, hypotension, plus you need to show that there is free fluid on ultrasound scan through and fast scan. If there is signs and symptoms suggestive of peritonitis, that is inflammation of peritoneum by suggestive of guarding and rigidity. If there is guarding and rigidity is present on examination, it is suggestive of peritonitis. This patient needs to be taken for surgery. Any air under the diaphragm on a CT scan or any visceral injury on a CT scan, this is an indication for laparotomy. So we are into the circulation. So everything what we see is in the circulation. First thing is stop the bleeding. So you might have to do a direct compression, or you might have to do a packing and do a compression to stop it. If that is also not successful, you can place a tourniquet. Do an abdominal and pelvic examination, apply pelvic binder. Do and fast scan. Look for any deformity in the thigh because femur fracture can cause hemodynamic compromise. So place and thermosplit if you find a deformity in the thigh. If you don't find any source here, then log roll the patient and look out for the source. If the patient is in shock, suggestive by hypotension, these 3 steps are super important. They are activate the major hemorrhage protocol, start the fluids. The fluid usually in adults it's given is 500 ml to 1000 ml. In small boluses, it is given till the blood products are available. Once the blood products are available, give O negative first till the cross-match blood is available. Once cross-match blood is available, give the cross-match blood. Assess the GCS. If it is a pediatric age group, you can use AVPU method. Use the lateralizing signs, temperature, deformity, everything else is same what we have discussed. The main thing what you need to see here is the circulation part, what I have mentioned here. Pass the slide, go through this again. This summarizes very well in this tabular form. Trauma in pregnancy, few things you need to remember. Don't forget there is one more living being. That is one more fetus is there. Always check the fetal heart sound, fetal heart rate with Doppler. Involve the obstetricians as soon as possible. If the pregnant lady is more than 20 weeks of gestation, there might be compression on the inferior vena cava. That's why you need to displace the uterus over the left side by tilting left lateral position. You need to place or you need to tilt the patient 35 degrees, or you might just manually mobilize the fetus towards the right side so that the compression on the left side you need to manually push the fetus towards the right side so that the compression on the IVC is relieved. IVC comes on the right side. So you need to push it towards the left side, baby. Or you need to place the mother in a left lateral position, ideally 35 degrees tilt by placing an wedge. It is kind of similar what we have seen in cardiac arrest. There is no difference. It is kind of similar to the cardiac arrest. Now we are coming to a specific injury, that is head injury. Classification is not important from OSCE point of view. You need to know when to get an CT scan done. That is basically CT brain done. You get it done within an hour's time if one of these following are present, which are GCS is less than 13 on presentation. GCS is less than 15 after 2 hours on assessment in the emergency department, or if you are suspecting an open or depressed fracture, or if there is any signs of basal skull fracture. Those are hemotympanum. Hemotympanum is one case. Raccoon eyes is another way. Another one is clear fluid through the nasal cavities. That is rhinorrhea, clear rhinorrhea if you're having. If any one of these are present, suspect in basal skull fracture. After trauma, if the patient had any focal neurological deficit or seizures, if there is more than 1 episodes of vomiting, go ahead and get the CT scan done within 1 hour, and there should be an verbal report available within 1 hour. If these are not there, see if the patient is on any anticoagulants. Yes, if the patient is on any anticoagulant, the CT scan should be done within 8 hours. If the patient is not on anticoagulant, was there any loss of consciousness or amnesia? Amnesia means he doesn't remember the incident. Loss of consciousness is lost his consciousness. If present, look out for this signs. If any one of these present, that is dangerous mechanism of injury, 1, or age more than 65 or equal to 65, or there is a retrograde amnesia of more than 30 seconds. If yes, again, you need to get the scan done within 8 hours. What are the dangerous mechanism of injury? Fall from height that is more than 1 meter or 5 stairs, axial load to the head, a motor head-on collision, basically any ejection from the vehicle or rollover of the vehicle, or the vehicle is speed of more than 100 kilometers per hour, or using any recreational motor vehicle, or it is a bicycle. These are the dangerous mechanism of injury. In the pediatric, when you are suspecting a non-accidental injury, post-traumatic seizures, on initial assessment, if the GCS is less than 14, if the child is less than 1 year, it is GCS less than 15. At 2 hours, GCS is less than 15. Or if it is a suspected open or depressed skull fracture, you're suspecting a basal skull fracture, same as you suspect in the adults. Any focal neurological deficit. This one people keep forgetting. For in children under 1 year, presence of bruise, swelling, or laceration of more than 5 centimeters on the head. If present, then you go ahead and get a CT scan done within 1 hour. If not present, then you see these features. What are these features? Loss of consciousness for 5 minutes, any abnormal drowsiness, more than 3 episodes of vomiting, dangerous mechanism of injury. Here it is height is 3 meters. In adults, it's 1 meter. Here it is 3 meters. Okay, that's the difference in dangerous mechanism of injury from adult to pediatric. Amnesia, any antegrade or retrograde amnesia if this patient is having. If more than 2 risk factors are there, you get the CT scan done within 1 hour. If only 1 risk factor is there, then you observe this patient for 4 hours. And in this 4 hours, if the patient is having low GCS or further episodes of vomiting or any abnormal drowsiness, you get the CT scan done within 1 hour. If there is no risk factor, none of these are present, then no imaging is required. You can discharge this patient with safety netting. So sometimes they might give an CT scan and ask you to interpret. So it is suggestive of an EDH. It is suggestive of an SDH as it is in concentric shape. This is more of an lens shaped. This is suggestive of an SAH because you can see in subarachnoid spaces blood is present. This is typically known as frog sign. So it's supposed to appear like a frog here. It's supposed to appear this as a frog. Sometimes there might be air because of the skull fracture inside the parenchyma, suggestive of a pneumocephalus. Sometimes there might be intraparenchymal bleed, as you see here. If there is an obvious head injury, you're done and CT scan, you know what can you done to prevent the secondary brain injuries. So what does NICE recommend? NICE recommend that maintain oxygenation. So prevent hypoxia, maintain PaO2 more than 13. Maintain carbon dioxide levels in the normal range. No normocapnia. So prevent hypoxia here. Okay, here you need to be in the normal range. PaCO2 should be there achieved. For achieving this, if required, intubate the patient. Okay, you need to achieve this. If required, go ahead and intubate. Maintain the MAP, mean arterial pressure, more than or equal to 80. Always make sure the patient is normoglycemic. Keep the head end position 30 degrees. Okay, the head end should be elevated to 30 degrees. That reduces the ICP. Next thing is give them good painkillers. If they're agitated, this might cause raised intracranial pressure. So things you need to verbalize in the exam is, I want to prevent the hypoxia, maintain normocapnia. Second point. Third point, head end elevation for 30 degrees. Fourth point, good pain management. To maintaining hypoxia and normocapnia, if required, I'll go ahead and intubate the patient. If you mention this, you'll get all the marks. Coming to, there might be a trauma case, basically a burn case. You go ahead and intubate prophylactically, or you go ahead and do an early intubation whenever you find these signs in a trauma case. That is, might be hoarseness of voice, respiratory distress, carbonaceous sputum, burned nasal hairs or facial hairs. There is inflammation of the oropharynx, any burns noted in the oropharynx or face, any history of burn in an enclosed area suggestive of an carbon monoxide poisoning, suggestive by raised carbon monoxide levels. In breathing, always initiate high flow oxygen. Sometimes the reading might show falsely low because of carbon monoxide poisoning, especially if it is an enclosed room where there was burning building in an enclosed area. They might have inhaled carbon monoxide causing carbon monoxide poisoning. So always suspect an carbon monoxide poisoning in a burn case. In circulation, place IV cannulas. If IV cannulas is difficult to place an IO. Preferably don't place in the limb where there are burns. If all the limbs are involved, then you can place it through the burn tissue also, no problem. Creatinine kinase in the investigations included. After this, you need to calculate the extent of the burn. The two formulas available. Easier one to remember is rule of 9. Unlikely a pediatric will come up, but just go through this. Remember the rule of 9. So 1/9 stands for head. Front part is 4.5, back part is 4.5. 2 9s for chest, 2 9s for the back. Front part, upper limb 4.5, upper limb backside is 4.5. Front part of the lower limb is 9, backside is 9. Okay, totally, and 1% goes for the genitals. So totally it will come to 100%. Similarly here, only the backside of the baby is 9%, front part is 9%, because the surface area of the head is quite large in the babies compared to that of the adults. Similarly, the upper limb 4.5 back and 4.5 front, same as the adults. Here 18% for the anterior part of the thorax and abdomen. Posterior part of the upper thorax, posterior part of the upper back and lower back carries 13%. Buttocks carries 2.5, 2.5. Anterior part of the thigh is 7. Posterior part of the thigh is 7. So it is not required from exam or any recitation or clinical point of view to differentiate between all different types of burns. You need to basically differentiate from epidermal burn, which is also known as superficial burn, from the rest of the burns, because epidermal burns or the superficial burns are not included in calculating the Parkland formula. So if you are able to differentiate it, that's enough. Superficial burns are just the redness, just the erythema, just the redness what you see. Other than the redness, anything is present, you include that in the body surface area. There are two different methods to calculate. One is RCM learning, one is ATLS formulas. In exam, you did not mug it up. You say you will use Parkland formula. What is Parkland formula? Just remember, for the adults, it's 2 ml into kg, 2 ml into the patient weight into the percentage of total body surface area, which is burnt. It is according to the ATLS. You just mention it off. This one, if you're using here for the adults, it's different. You're using 3 ml here. That is 3 ml into body weight in kgs into percentage of total body surface area of the burn. So you need to mention which one. According to RCM learning, I'm using a Parkland formula, that is 3 ml, that is 3 into body weight into body surface area. Or you remember the ATLS one. I recommend you to remember the ATLS one. It is an easier one. So according to the ATLS, I'll use the Parkland formula to give the fluid, that is 2 ml into kgs, that is body weight, into percentage of total body surface area. If it is not a resuscitation case, then you need to do is remove all the jewelries, irrigate it at least for 20 minutes and tap water, then cover it with a cleansed phlegm. Never forget to get an ECG in an electrical burns. Always shift this patient to burns unit. Coming to here. So in a burn case, always look for hoarseness of voice, stridor, sebaceous sputum, and single nasal or facial hairs, any burns on the face or oropharynx, needs and definitive airway. Okay, you intubate this patient before you go into the breathing. In breathing, remember that SpO2 might show falsely low because of carbon monoxide poisoning. Request for blood gas. In blood gas, you can see the carbon monoxide levels. If the patient is in shock, in circulation, resuscitate. You're not using Parkland formula here. Remember, you are resuscitating like a normal case. So you are giving an boluses of 500 to 1 liter, 500 ml to 1 liter, repeated bolus till the blood pressure picks up. Here, there is no loss of intravascular volume. There is only third spacing of the fluid. That's the reason the patient is in hypotension. So you are just giving lot and lot of fluids. The next thing is, if the patient is not in shock, then you say you are using Parkland formula to give the fluids. So you can calculate the body surface area in the circulation itself, the body surface area of the burns which is involved, or you can do that in the exposure part. Disability is just the GCS part, and everything else remains the same. Need not worry. Coming to secondary survey, you are not expected to do the secondary survey, or you shouldn't, or you should never ever go into a secondary survey till in primary survey the patient is stable. So airway is stable, breathing is stable, circulation is stable, deformity is done. So all A, B, C, D are stable. Then only you can enter into the secondary survey. If you have time and you have entered into the secondary survey, that means you have passed the station. Usually they don't expect you to enter into the secondary survey. Usually the management will be in the primary survey, and you'll be able, they're expecting you to complete only primary survey in the management. So in the secondary survey, if you're able to enter, so examine HEENT, where H stands for head, E stands for eyes, another E stands for ears, nose, throat, followed by chest examination, followed by this N also stands for neck, followed by bilateral upper limbs, abdominal and pelvis examination, bilateral lower limbs, and log roll the patient. Sometimes in circulation, you might not find any source of bleeding. That's when you need to log roll and see. It might be it might be back of the patient. There might be some injury which is causing the blood loss. So always log roll in the circulation itself should not find any source of bleeding. Thank you.